We are so glad you're here today. We have two terrific presenters, but I first want to tell you that we are recording this session today, and this session will be posted hopefully by the end of the business day today, if not tomorrow morning, to our YouTube page at UT Tyler. And so you will see as we go through the disclosure slides, there is a slide that has multiple social media QR codes. I've got an affinity for QR codes lately, and so I've put them all on one page here for you. Feel free to jump on in. Thank you, Meredith. We've got the LinkedIn, the YouTube, and the Facebook page. So feel free to look at everything we've done in the last 3 years. And again, this one will also be posted a little bit later on. So today we have two presenters from the UT team down in Galveston, UTMB. We have Dr. Shotwell and Dr. Garcia. And let me tell you a little bit about these two individuals here. I have Dr. Elena Garcia, and she is a licensed psychologist and assistant professor at the University of Texas Medical Branch in the Department of Psychiatry and Behavioral Sciences. Dr. Garcia received her doctorate in clinical child psychology from Howard University in Washington, D.C., and completed her pre-doctoral internship with a child trauma specialization at the University of California, San Francisco School of Medicine multicultural clinical training program. Additionally, Dr. Garcia completed her postdoctoral fellowship at Texas Children's Hospital, Baylor College of Medicine, where she specialized in providing trauma and grief clinical services for youth and families in outpatient and foster care settings. She additionally conducted research on topics including post-traumatic stress, suicidal ideation, and sleep problems in children and adults. Currently, Dr. Garcia provides evidence-based assessment and treatment for Texas schools through the TCHAT initiative. And for those of you who have been with CPAN, you've heard of the Texas Child Health Access Through Telemedicine initiative, another one of our consortium initiatives focused on assisting with the mental health of children here in Texas. Dr. Garcia aims to advance the field of clinical psychology through clinical services, research, training, and teaching. She has a specialized interest in trauma sleep-related problems among Black, Indigenous, and people of color youth, and is dedicated to improving access to mental health care for underserved youth and families. Our second facilitator today is Dr. Joseph Shotwell. And Dr. Shotwell joined the University of Texas Medical Branch Psychiatry faculty in 2018 as an assistant professor of child and adolescent psychiatry. He received his medical degree from UTMB and completed both his general psychiatry residency and child psychiatry residency fellowship training at UTMB. Dr. Shotwell provides care to children in a variety of clinical settings, including the UTMB outpatient clinics, school-based clinics, and hospital consultations. His primary role at UTMB is leading the TCHAT program, which I explained a bit earlier, delivering telemedicine services to Texas youth in the school setting. Dr. Shotwell is involved in medical student education, advising, and clinical supervision, and he also serves as the clinical supervisor to psychiatry residents and fellows completing their training at UTMB. Dr. Shotwell is active in the American Academy of Child and Adolescent Psychiatry, as well as the Texas Society for Child and Adolescent Psychiatry. He's involved in researching the effects of trauma on youth through children, the Texas Child Trauma Research Network. So we have a couple of really excellent presenters today. They both have an interest and focus in trauma. And I think today's session in discussing, recognizing, and treating eating disorders is going to be an excellent session for you. So I'm going to go ahead and turn this over. Who will be running the slides? Will it be you, Dr. Garcia, or are you, Dr. Shotwell?
Yes, I'll do it.
Okay, great. Are you familiar with Teams? Some people are Zoom people.
I am definitely a Zoom person, but I think I got it. Give me one.
Okay, great.
I think I can do it. All right.
And I'm going to work on my camera as we start here.
Wait. That didn't work. Okay, hold on. Let me try again.
Okay. Success. Yes, ma'am.
I do this meeting.
All right, I'll turn it over to you.
All right, thank you so much.
Oh, yeah, sweet. Yeah, this morning flew by. What do you do?
Oh.
I'm good.
Yeah. All right, well, good afternoon, everyone. Thank you so much for joining us today. Dr. Shotwell and I will be presenting on recognizing and treating eating disorders in primary care. This is a topic that I have a lot of familiarity with, something that I treated while working at Texas Children's. And so I'm really passionate about this topic. And of course, feel free to ask any questions as we're going through as well, too, and at the end. Great. So for today's presentation, just an overview. So I'll start by providing a background of eating disorders. We'll discuss how to identify clinical symptoms. I'll discuss the assessment and diagnostic process. We'll discuss identifying varying levels of care, the treatment intervention, so psychotherapy and pharmacotherapy, and then finally discussing psychoeducation for patients and caretakers. So to begin, in the US alone, an estimated 20 million women and 10 million men have or have had an eating disorder at some point in their life. And although eating disorders can affect anyone at any stage, they are most often reported in adolescents and young women between the ages of 12 and 35. And studies have shown that up to 13% of youth experience at least one eating disorder by the age of 20. Eating disorders can cause tremendous emotional suffering and significant medical consequences, and they have up to a 10% mortality rate. So eating disorders, they actually have the second highest mortality rate of all mental health disorders, surpassed only by opioid addiction. And the mortality rate for people with eating disorders is up to 6 times higher than that for people without eating disorders. Specifically, anorexia, which I'll discuss a little bit more later, has the highest mortality rate of all eating disorders and is estimated around 10%. And this is due to the fact that in patients that have anorexia, they are severely restricting their caloric intake, which causes the body to consume muscle tissue for fuel, including heart tissue. And then, so of course, as the heart has less fuel and fewer cells to power the system, their pulse rate and blood pressure drop, which increases the risk of heart failure or fatal arrhythmias. And among those who struggle with anorexia, 1 in 5 deaths is by suicide. So I share all that to start just to really show the severity of eating disorders and how important it is for us to be assessing for and diagnosing this so we can give adequate treatment. So eating disorders are characterized by severe and persistent disturbances in eating behaviors with associated distressing thoughts and emotions. They can exhibit a variety of symptoms, including the severe restriction of food, binging, and/or purging behaviors. They often co-occur with other psychiatric disorders, and they're caused by a complex interaction of genetic, behavioral, psychological, and social factors. So there isn't one cause for it. And so when we are assessing for eating disorders, we have to take into account that they also often co-occur with other mood and anxiety disorders. So for example, you may see some signs of OCD or alcohol and drug abuse problems as well too. A significant amount of people with an eating disorder show signs of an anxiety disorder before the onset of their eating disorder. And according to the National Center on Addiction and Substance Use, up to 50% of individuals with eating disorders abuse alcohol or illicit drugs at a rate 5 times higher than the general population. So transitioning into types of eating disorders. So the first type is anorexia nervosa, which I mentioned initially. And so this is the restriction of food intake causing abnormally low body weight, intense fear of gaining weight, and a distorted perception of weight or shape. So for children, criteria include less than 85% of body weight expected for age and height, or failure to gain weight during a growth period, leading to body weight less than 85% of that expected. School-age children may not endorse a fear of gaining weight or body image disturbance, and so you would pay a lot of attention to their diet, their eating habits, and getting a lot of report from their parents as well too. Another category of anorexia is also called atypical anorexia. And so what that is essentially you will see all of the same signs and symptoms as anorexia, just without the weight loss piece. Then next is bulimia nervosa. And so this is recurrent binge eating episodes with an associated sense of loss of control over eating, followed by methods of purging. So both the binge eating and purging occur on average at least twice a week for 3 months, and they must not meet the criteria for anorexia nervosa to obtain this diagnosis. If you have a patient that does meet the criteria for anorexia diagnosis and they also are binging and purging, then you would diagnose them with anorexia with a binge purge subtype. The next is binge eating disorder, and so this is frequent episodes of excessive overeating without purging. And then pica is persistent eating of substances that are not food and do not provide nutritional value. So you may see people eating dirt, paper, soap, charcoal, ash, clay, chalk, etc. The next is rumination disorder, so repeated voluntary regurgitation of food recently swallowed with the intention to re-chew and re-swallow or to spit out. And then finally, avoidant restrictive food intake. So this generally develops during infancy or early childhood, and it involves a disturbance in eating, either due to a lack of interest in eating or intense distaste for certain smells, tastes, colors, textures, or temperatures, resulting in dramatic weight loss and nutrient deficiencies. This also can include a fear of vomiting or choking. So especially if you see a younger child who may have had a choking experience, they may develop ARFID. So as we are assessing and thinking about eating disorders, it's important to be able to have in mind what some of the emotional and behavioral symptoms are that are associated with these different types of eating disorders. And so some common things that you may see are extreme preoccupation with weight loss, dieting, food, and eating. So you may see a patient that is very, very preoccupied with their calories, they're tracking their calories, their carbs, fat grams, they're frequently dieting, like I mentioned, refusing to eat whole categories of food, staying away from certain types of food. They may have some food rituals like excessive chewing, measuring out their food, or eating only one type of food for every meal, skipping meals, or eating very small portions of food during their meals. And then you may also see that they drink excessive amounts of water or use excessive amounts of mouthwash, mints, or gum, and also might often eat discreetly away from others. Then you may also see that they're preoccupied with their appearance, so frequently body checking, so checking different parts of their body in the mirror, going to the bathroom right after meals, dressing in layers to hide the weight loss or to stay warm. Then compulsive exercising, so they may maintain excessive rigid exercise regime. So asking about exercise is very important. You may have some patients that are exercising multiple times a day, right before bed, in the morning. And so getting an understanding of what their exercise schedule looks like is helpful. And then the binging and purging behaviors. So patients may have a presence of packages of laxatives or diuretics hidden in the room or bathroom. You may see behaviors of stealing or hoarding food or presence of large amount of food wrappers that are hidden as well. Then isolation, so they may withdraw from usual friends and activities, not wanting to go out to eat with friends or family as well too. And like I mentioned earlier, you may see some signs of anxiety or depression, some OCD type symptoms, some extreme mood swings, and then their self-esteem may start to fluctuate based on their eating habits. Okay, I'm going to turn it over to Dr. Shotwell.
Sure. So thank you, Dr. Garcia. As with most things in medicine, primary care is definitely on the front line when it comes to treating eating disorders. Most of the time, patients that come in to see primary care providers aren't coming in saying, I think I have an eating disorder. Instead, they're really coming in with a variety of vague symptoms that are often pretty nonspecific, and it's up to the clinician to get a good history and figure out that the symptoms are secondary to an eating disorder. So what are some of the signs or symptoms that you might see for someone coming in that could potentially tip you off that it could be an eating disorder? So it could be something like dizziness, fainting episodes, poor concentration or brain fog, headaches, all of which could be signs of volume depletion or dehydration. It could be a parent bringing their kid in because they're noticing huge fluctuations in weight, either up or down. It could be a variety of GI complaints. So parents bringing their kids in with complaints of chronic constipation or frequent episodes of nausea, vomiting, amenorrhea or absence of the menstrual cycle could be a reason that parents come in, or delays in puberty. You may also see patients referred to you with laboratory abnormalities or abnormal vital signs, or you may pick this up from visit to visit and well child checks or annual visits. Patients could also come in for something like cold intolerance. Some things that aren't on this list, but I wanted to mention as well, chronic fatigue. That's a pretty common reason that people who aren't obtaining enough calories come in to see the doctor, is because they are fatigued and malnourished. Another one is excessive sleep. So patients that aren't taking in a lot of calories may not have a lot of energy, and they may spend a significant amount of their time sleeping. Next slide, Dr. Garcia. Some other things that you may see, patients coming in with a variety of dental problems, abscessed teeth, numerous cavities. You may see patients coming in with inflamed throat, sore throat, swollen salivary glands, blood in their vomit, dry skin and hair, brittle nails, muscle weakness, loss of muscle mass, poor wound healing, or impaired immune functioning. And with the impaired immune functioning, you may see them come in a variety of times for simple infections, but in a repeated nature. The point here is that there's really a lot of different symptoms that go along with eating disorders, and so you have to kind of keep eating disorders in mind when you're seeing these patients, because any one of these symptoms could be the presenting symptom for an eating disorder. Next. Let me just mute this person. Okay. And because the symptoms that people come in with can be pretty nonspecific and variable, your differential diagnosis when it comes to patients with eating disorders can be pretty broad. So as I mentioned, patients could come in with a variety of different GI complaints, and so you have a list of things that are GI related that could be going on. Some of the examples are celiac disease, Crohn's disease, ulcerative colitis, gastroparesis, GERD, pancreatitis. We also have to be on the lookout for endocrine conditions, things like thyroid disease, type 1 diabetes, pregnancy, prolactinomas, Addison's disease, congenital adrenal hyperplasia, growth hormone deficiency. You also have to be thinking of oncologic causes, things like brain tumors, leukemia, lymphoma, also inflammatory conditions or rheumatologic conditions, things like rheumatoid arthritis, lupus, any of the autoimmune conditions. Keeping your mind open that it could be something genetic. So someone coming in with binging episodes could be the presenting symptoms of Prader-Willi syndrome. Someone coming in with absence of menses could be presenting symptom of Turner syndrome. So a variety of genetic things have to be kept in mind as well. Coming in with weight loss, vomiting, electrolyte abnormalities could also signal renal failure. There's also some neurologic conditions, particularly neurodegenerative disorders, that you need to be keeping in mind that may result in protein wasting or musculoskeletal abnormalities. A variety of vitamin deficiencies. So someone comes in and they're not tolerating the cold, they're having brittle nails, their hair may be falling out. That may be something to keep in mind, some sort of vitamin deficiency, B12, thiamine, zinc, iron, vitamin D. There's also some other conditions to have on your radar, POTS, or postural orthostatic tachycardia syndrome. Some less common conditions, but things to keep in mind, particularly depending on what kind of population you work with, HIV, tuberculosis. Another big thing is other psychiatric disorders. So it's pretty common, as Dr. Garcia mentioned, for patients to come in and have comorbid psychiatric conditions going on, but you may think that your patient's symptoms are due to an eating disorder, and it could be due to something else, something like autism spectrum, depression, anxiety. Likewise, if your patient's on medications that are psychiatric medications, those medications tend to have a lot of side effects. So looking out for weight gain or weight loss as a potential side effect of medication. Something that's not on this list, but I also thought we should add, substance use. So a lot of the symptoms that you might see for a patient with eating disorder could be, a sign that a patient's abusing substances. All right, back to you, Dr. Garcia.
Yes, thank you. And so, as Dr. Shotwell just mentioned, there are a lot of things that need to be considered when you are assessing a patient that potentially may have an eating disorder. And so that makes the assessment and diagnostic process so important, so that way we can identify the signs and the symptoms and get them the right diagnosis and treatment as early as possible. Their outward appearance, it may not always indicate an eating disorder, and certain behaviors can seem like a normal part of dieting, which is why it's really important to ask the right questions. So you see these 5 questions here on the screen. So this is a brief screening that can be used in primary care. And so it asks about being satisfied with their eating patterns, if they ever eat in secret. Does their weight affect the way you feel about yourself? And then also gets a slight history of eating behaviors in the patient's family and their personal history of eating disorders. So have any members of your family suffered with an eating disorder, or do you currently suffer with, or have you ever suffered in the past with an eating disorder? And so while this tool can be a helpful first step, it should definitely be followed up by a full psychological test if an eating disorder is suspected. And there are longer and additional screening tools that are available to assess for eating disorders. And so as you continue forward with the assessment process, one part of it is the patient assessment. And so this is where we would obtain the patient history and determination of their current medical and nutritional functioning. During this assessment, you should also explore other mental health conditions such as suicidality or self-harming behaviors, depression, or anxiety, in addition to the medical and mental health family history. And so, like I mentioned, the early detection is very important in preventing an eating disorder from progressing to a more severe or chronic state. And so in addition to the patient assessment, it's also very helpful and necessary to perform medical exams as well too. And this will assess for malnutrition or purging. And so you can look for some of the symptoms that Dr. Shotwell just mentioned. So some dental issues, dehydration, some of the various medical issues that can result from self-starvation or over-exercise, binge eating, and purging can be seen through the medical exam as well too. And so completing a full physical examination is needed. So their height, their weight, their body mass index, the growth chart, their cardiovascular and peripheral vascular function, skin health, hair loss, and evidence of self-injurious behaviors. These can all help you to determine what you're seeing for your patient. And then it's also recommended that laboratory testing is completed as well too. A variety of blood work and additional tests will help to determine the correct eating disorder diagnosis and assess appropriate levels of care. And so the levels of care, when we're deciding what to recommend for a patient, it comes from the interaction between how medically compromised the person is and how difficult they are finding it to not partake in the disordered behaviors that are perpetuating their illness. So according to the American Psychiatric Association level of care guidelines for patients with eating disorders, when you're determining the level of care needed, you want to always assess a patient based on several categories. So their medical status, suicidality, weight as a percentage of their healthy body weight, their motivation to recover, co-occurring disorders, the structure needed for eating and gaining weight, their ability to control compulsive exercising and purging behavior, environmental stress, and geographic availability of a treatment program. And so some things to keep in mind when you are trying to decide if a patient is appropriate for outpatient care, you really also want to check to see how strong their family and caregiver support is, because when patients are recovering from eating disorders, they often need a lot of support to help them stay on track. And if they have higher motivation levels as well, then outpatient treatment would be more appropriate for them. Okay. Keep in mind too that patients may move between various levels of outpatient care during the course of their eating disorder treatment.
So when do we need to consider sending a patient to the hospital, emergency room, admitting them? When are they unstable enough that inpatient is the level of care that they need? So for primary care providers, this list probably seems pretty straightforward to you all. Things that you would consider, reasons that you would want to put someone in a hospital, particularly if they had an eating disorder. So if their weight gets to a point where it's 75% or less of their ideal body weight, when you start seeing really huge swings in their vital signs, so heart rate being less than 50, systolic blood pressure less than 90, of course, depending on age of the patient, when someone's body temperature is so low that they're starting to develop hypothermia or at risk for something like that, although definitely not in our recent weather, orthostasis or syncope, also vomiting blood would be something that would be concerning and needs further investigation. If you have any concern at all that someone may develop an arrhythmia, whether that's based on underlying cardiac status, a recent EKG, or just electrolyte disturbances kind of in general. Next slide, Dr. Garcia. Okay, so what if they are not doing well, but they're not at a point where you feel like they need to be in the inpatient medical unit? When would you consider that maybe you need to send them to an inpatient psychiatric unit, particularly one, hopefully, that specializes in eating disorders? So I would say when you start to see patients having a lot of medical problems secondary to their eating disorder, maybe it's not serious enough that they need to go to the emergency room or be in an inpatient pediatric facility, but it's serious enough that you're getting concerned about it and it's progressing. I would also say if someone has significant psychiatric comorbidities, for instance, someone with ongoing substance use, someone with psychosis or psychotic symptoms, someone with severe depression, threats of suicide, self-harming, those could all be reasons that you would want to put this patient into an inpatient psychiatric facility. Significant food refusal. So if you have a patient that you're treating and they're doing okay, maybe not making a significant amount of progress, but they encounter some sort of really significant life stressor, and suddenly they're refusing to eat completely, and you're concerned about their ability to maintain hydration and maintain their health, that might be a reason to put them in a hospital type setting. As Dr. Garcia mentioned, the treatment for eating disorders requires a lot of support, a lot of family support, and a lot of clinician support. If you feel like the family is not able to maintain an environment that's supportive enough for the patient, you might need to consider hospitalizing them until you get them a little bit better, a little bit further along in their treatment. Also, failure of outpatient treatment plans. So if someone's been seen long-term outpatient and they're either not making progress or they're starting to slide back, sometimes resetting things with a trip to the inpatient hospital is what the patient needs. So now we're going to switch gears a little bit and talk a little bit about the treatment options for eating disorders. We should have switched it around and put psychotherapy first, because that's really first-line treatment for eating disorders. But since this is the slide we're on, I'll go ahead and talk about it. So I will start with the disclosure that there are not any FDA-approved medications for treating eating disorders in youth. Psychopharmacological interventions are pretty limited, particularly if someone's acutely compromised medically. You have to keep in mind that this population, like someone with anorexia or bulimia, having electrolyte disturbances, they're going to be high risk for developing arrhythmias. Most of our psychiatric medications increase the QT interval, so we have to be a little bit careful using medications in these populations. Oftentimes when we are using medications, it's not to treat the eating disorder itself, but rather to target comorbidities, in particular mood or anxiety. It's pretty common to use antidepressants in this population. As you can see, if you're going to consider an antidepressant, one that you might consider is fluoxetine. There's at least some studies in kids in terms of eating disorder symptoms like bulimia that would suggest that it could be a helpful treatment. I will also point out there's a few antidepressants that you want to avoid in this population. So there's specifically warnings on Wellbutrin or bupropion, stating that it should not be used in patient populations that have eating disorders, particularly bulimia, as the combination of electrolyte abnormalities and lowering of the seizure threshold from the medication puts patients at risk of seizures. I would also say you want to avoid medications like citalopram that's known to prolong the QT interval, as well as diprazidone, which is an antipsychotic, and also tricyclic antidepressants. Not that most of us use those in children much, but if looking for a treatment option, that would be very low on my list. When you're not treating comorbid conditions, the other way that you're treating pharmacologically eating disorder patients is really trying to find a medication that might help to stimulate their appetite or help them to gain weight. So one that's used fairly often, particularly in inpatient treatment facilities for eating disorders, is the olanzapine, which is the generic for Zyprexa. This is a medication that can cause some pretty substantial weight gain in patients. That's something that you have to be very mindful of when you put patients on it. Speaking from experience, using this in an outpatient setting with adults, I've seen someone gain as much as 60 pounds in 3 months on olanzapine. So you can have some pretty significant weight gain, and with that quick weight gain, you put patients at risk of developing something like diabetes, hyperlipidemia. So there are a lot of things to kind of factor in of whether or not you want to give them something to stimulate their appetite and help them gain weight. Another one that's not mentioned on the slide, but you might want to keep in mind, if you have a patient coming in and their primary complaints are low appetite and they're having difficulty with sleep, mirtazapine, which is the generic for Remeron, is another medication that's frequently used in this population to help stimulate appetite, particularly for patients with anorexia.
Okay. And so when considering psychotherapy, so like Dr. Shotwell mentioned, this would be the first approach when treating eating disorders. And there are several different types of approaches that could be used, but treatment plans should be tailored to individual needs. And it is likely to that you might combine some strategies from different types of therapy as well too. Okay. So one of the most common ones that's used is cognitive behavioral therapy, and this really aims to identify the distorted thinking patterns and inaccurate beliefs that contribute to an eating disorder, as well as strategies to modify and manage them. This is most commonly used with a patient that has a diagnosis of bulimia. And then the second one that is very commonly used, I'll discuss, is family-based therapy, or FBT. So this one is very popular for anorexia or atypical anorexia. And so like we mentioned, having family member support and clinician support is very important in the recovery. And family-based therapy heavily involves family members in their recovery by helping the patient to maintain healthy eating patterns and a healthy weight and interrupting unhealthy behaviors such as binge eating or purging. It's been found that this is typically most effective. And so family members are present for each of these sessions and involved in each session as well too. And then if you were to use any of these other approaches, so dialectical behavior therapy would focus on managing difficult emotions in conjunction with certain skills that are learned to replace maladaptive eating disorder behaviors. Acceptance and commitment therapy focuses on accepting all feelings, including the unpleasant ones, and committing to changing a person's actions to better align with their core values. And then CRT, cognitive remediation therapy, it targets rigid thinking processes considered a core component of eating disorders through simple exercises, reflection, and guided supervision. And then the last one that I missed was interpersonal psychotherapy. So that explores an eating disorder in the context of social and interpersonal relationships. But like I mentioned, you most commonly would probably use cognitive behavioral therapy or family-based therapy. So transitioning into psychoeducation, being able to educate caretakers about the physical and behavioral signs of an eating disorder is very important because the parents that suspect that their child has an eating disorder, they're typically going to seek help from their child's pediatrician. And so the early recognition of symptoms and early interventions are correlated with improved treatment outcomes. So the more information that parents have, the better they can be with being able to pay attention to some of the differences that may be happening with their child. This can also help to reduce some of their distress and negative caregiving experiences, as well as reducing some guilt and shame as well too. And as a provider, we want to always talk openly about concerns and use non-stigmatizing language. So we want to try not to make any judgments about a patient's weight, even if they are positive, as it may reinforce that weight is more positive than health. We also want to be careful as we do get into treatment of using any sort of like labeling words for weight. So if a patient is gaining weight and that's our goal, and you're weighing them at each session, trying not to say something like, oh, great, you gained 3 pounds this week, because that might not actually be very helpful for the patient to hear as they're still struggling with the weight gain. We also, like I mentioned, we want to encourage caretakers to talk openly about their concerns with the person who's struggling with the eating or body image problems. So being able to openly and calmly discuss concerns with your child about the behaviors and changes that you're observing is important. So recommending for a parent saying something like, I've noticed that you aren't eating dinner with us anymore, or I've noticed that you've spent a lot of time in the mirror lately, or you're going straight to the bathroom after meals. Okay, so that allows children and teens to know that they're okay. So that allows, sorry about that. That allows parents or your child to know that parents are able to validate what's happening. They're recognizing what's happening as well too. And this is helping parents understand that we shouldn't avoid or ignore what's happening, but rather acknowledge it and discuss openly. So as a provider, we also want to be prepared for negative reactions. So some eating disorder sufferers are glad that someone has noticed that they're struggling. However, some might become very angry, hostile, defensive. Okay, they may brush off concerns or minimize the potential dangers, and all of these responses are normal. And so as a provider, we want to just reiterate concerns. Parents can also just let them know that they care and leave that conversation open. We also want to maintain neutrality, so helping patients acknowledge the severity of their behaviors and their illness, ask open-ended questions, try to diffuse the blame, help families understand that they did not cause the illness as well too, nor did the person with the disorder choose to have it. So in these scenarios, having a family meeting can be very helpful, as well as using language like referring to the eating disorder separate from the person. So the eating disorder caused this, or not, instead of saying that the child or the parent caused this. That helps to diffuse the blame. Okay. And then finally, we want to make sure that we are also monitoring social media activity. So explaining to parents that this is a time to really pay attention to what their children and teens are viewing on social media. Okay, so sometimes they may need to take a break from social media if it's impacting their mental health or their body image. While social media is a great tool to stay connected, it can also have a lot of really concerning trends or challenges. So one concerning trend is the body checking trend that's made its way to TikTok and Instagram, and it has the hashtag of body checking. And so this is encouraging patients to kind of engage in some of that unhealthy behavior. We really want to help parents and patients, encourage them to unfollow accounts and hashtags that make them feel bad about themselves. One recent disturbing trend that has come up is called a pro-Ana site, which are easily accessible websites and blogs that support practices like anorexia and bulimia that provide information on how to maintain an eating disorder and also give tips for weight loss. So again, we want to just really encourage parents to monitor their children's social media so that way we know what they are seeing and viewing online. All right. And so Dr. Shotwell and I are going to transition to 2 case presentations. So I'll read through this and then ask for any thoughts that you can either unmute and say or put in the chat. So the first one is, Haley is a 17-year-old female who presents to the clinic with her mother. Her mother informs you that she is concerned because Haley refuses to eat dinner with the family, has become extremely selective with foods, constantly weighs herself, seems irritable often, and is frequently exercising in her room. Haley's weight has always been at the 80th percentile until 6 months ago when she started a low-carb diet and started running. She lost 20 pounds quickly and started receiving positive attention for it. Her mother informed you that another physician gave her positive feedback and she kept going. Now her weight is at the 40th percentile and she informs you that she has no energy and her hair is falling out. So any thoughts on what the first step would be if this patient presented in your clinic?
Please feel free to unmute yourself. It's great to have an interactive case presentation when possible.
And so a hint, we always want to be thinking about assessment and evaluation, right? And so the first thing that we would want to make sure we start with is the evaluation. So I see in the chat, consider checking labs, including thyroid. Great. So paying attention to getting those medical labs in the exam. So that way you can have another understanding of what is happening. Any other thoughts of how we would approach this type of case?
Dr. Garcia, wouldn't we also ask her how she feels about her weight loss?
Yes, definitely. So understanding that the thoughts and the emotions that are associated with the weight loss. So is this something that she is doing purposefully and really trying to lose the weight? Is she very preoccupied with her weight as well too? Asking about her current weight and how she views her body. Great. And then, so we've gotten the answers to these questions, and then what would we probably consider to be next step for Haley? So yeah, so talking about health in general, not focusing on the scale, focusing on how your body is feeling and functioning. Great, so having that sort of psychoeducation conversation with her as well too.
Referral to therapy.
Yes, definitely. So we'd want to refer to therapy, refer if you're unable to get the full assessment in this session, then we definitely want to follow up with a full evaluation by either a psychologist or psychiatrist. Yep, giving a PHQ-9, perfect, so we can learn more about any comorbid things that are happening, especially wanting to understand if there's any suicidality or self-harm. And CPAN can assist in finding specialized counseling for Haley. Yep, perfect. Thank you. Okay. Great. Yep, using the EAT26. Yep, that's a great eating disorder screening to get more specific information about the eating disorder concerns. And then one last thing that I do want to point out here that would kind of ring a bell in my head if I were reading this is that Her mother informed you that another physician gave her positive feedback about the weight loss and she kept going. And so that's just one of the things to keep in mind when we talk about like using non-stigmatizing language or non-judgmental language, regardless of whether or not weight loss might be a positive thing for a patient. We want to be careful in how we are giving and providing that feedback, because it may spiral into more severe concerns following that visit. All right, good job. I'm going to switch to Dr. Shotwell's now.
Okay, so I took a little bit different approach on the case presentation. So this is John. He's a 15-year-old male. He presents to the clinic with his mother. He's concerned that he may have ADHD. He mentions that his friend takes Adderall and he's interested in starting this medication. In talking to John's mother, she has no concerns about ADHD and she really thinks John wants to start this medication to help him lose weight. He's currently greater than the 99th percentile weight for age, and his mother reports that John's weight tends to fluctuate about 20 to 30 pounds over the course of a year. In interviewing John and talking about his weight, he really wants to lose about 50 pounds. He admits to having frequent binging episodes 3 to 4 times a week, and after binging, depending on how guilty he feels, sometimes he ends up purging a couple of times per week. He's also exercising excessively 2+ hours on the days that he has binging episodes. He asks you to proceed with prescribing him a medication to help reduce his appetite. As I mentioned, in particular, he is looking for Adderall. So I don't know if anyone on the call experiences cases like this. I see them fairly often in the adult psychiatry world, but I think as Dr. Garcia mentioned, there's a lot of information out there on the internet, and teenagers get smarter and smarter every day in terms of coming in and telling us symptoms and pointing us in one direction or the other. So I'm interested to hear if anyone's had similar experiences with patients like this. Yeah.
Yes, I have.
Yeah. It also sounds like someone in the chat said, doesn't sound like ADHD, it would be a pretty late diagnosis. And then also I think the patient's parent, confirming that there really haven't been any concerns. And then also I didn't give you anything in this question stem that would make you think that there were academic struggles, behavioral concerns, anything like that. Just a patient reporting concerns he might have ADHD and really wanting to be on a stimulant medication. Other thoughts or things that people would like to mention about the case?
I refer for a binge eating disorder to counseling to hopefully help this kid learn how to eat, or to hopefully learn to overcome this now versus as an adult.
Yes, I'm actually glad that you mentioned that. So this could be a presentation of binge eating disorder, and certainly there are treatments for that are pharmacologic for adults. And guess what that treatment is? Vyvanse or lisdexamfetamine. So there are treatments that are stimulant based that treat this kind of condition in adults. They're not approved for that specific use in children, but that may be something that John encountered when he was looking online and looking up his symptoms and seeing what sort of treatments might be available out there. So definitely something to keep in mind. And it may be that it's something that you could consider down the line using a stimulant off-label to help this patient manage his appetite. But I think the big takeaway is that you need a little bit more information. You need to really focus on the pathology that's the eating disorder and maybe go at it a little bit different angle than just prescribing a medication right away. I think as people have put in the chat, screening for symptoms of depression, anxiety, maybe looking at things that are going on in the household, environmental factors, talking about the diet, going through all those sort of things rather than just have a knee-jerk reaction of prescribing a medication in this kind of situation.
I I wonder too, Dr. Shotwell, I think about that 15-year-old and, that's kind of the beginning of high school. Things change quite a bit then at that 15-year-old age. He obviously is interested in losing weight. Maybe this is the first time that he is interested in making that change. So not only the question of, how are you feeling about your weight, but also what other things have you done to try to impact your weight? And would it be appropriate if he's interested in an RD referral?
Yeah, I think so. I mean, definitely getting a lot more history on the patient and what he's been doing so far. How is his eating? What is he doing to manage his weight? Those are all things that you would want to know. Something else is, depending on the individual person, some people may be a little later to hit puberty. So this could be a patient going through puberty and suddenly having quite a bit of weight gain associated with that. Yeah, someone else pointed out could be some specific things that are motivating him to lose weight. So maybe he wants to be on a specific sports team, or needs to be in a certain weight class if he's doing something like wrestling or martial arts or something like that. A lot of things to consider for sure in all cases like this. Someone's asking a question that I'm not sure that I know the answer to, because I'm not sure which area they're in, but are there dietitians that they can refer to?
Dr. Shotwell, that is our area. Christus is a large health system here. There are, as my understanding, independent registered dietitians that are available. I know that there are specialists actually in the Tyler area that specialize in eating disorders, and one of them is a registered dietitian that works in that. So there are those specialty. Unfortunately, some of them are cash pay only, which can be expensive for the family. But that's where you could contact CPAN, and we would do that research for you and get that back to you.
The other place that I'll say there's often dietitians located is within an endocrinology practice. So when you have a lot of patients that have diabetes, meeting with dietitians is a pretty regular thing in that kind of clinic. And so you may be able to refer someone to a dietitian in that specialty as well.
Right. Well, that concludes our presentation today. Are there we have a couple more minutes, any questions from anyone?
While we wait for another question, one of the areas that we as CPAN are moving into and expanding our services is into the perinatal space, that pregnancy and postpartum, 1 year postpartum. And certainly as an MCH nurse, I've worked with young women who have had eating disorders and then gotten pregnant. And so not that is the specific topic today, but do you have any thoughts for those family medicine providers of things that may be a little different, or do we look at that the same way? Because you obviously have two patients there, not just the one, and then there's not just the pregnancy time, but then postpartum as well.
Yes, I would say that in this scenario, it's really important to assess for their motivation level and also their access to support, because of course you have, like you mentioned, two different patients that you're treating at this point. And so those two pieces I would say would be really vital to understanding what the next steps of treatment would be for someone in this position. And so if their motivation levels are especially low, then we might want to consider like going ahead first step with doing an inpatient treatment until they're medically stable and able to transition out to outpatient care. But I would say that the treatment looks virtually the same, but we are just giving special consideration to levels of motivation and access to support.
Yeah,
Thank
just
you.
speaking from the like pharmacology standpoint, definitely a consideration would be if someone's in the postpartum period and they're breastfeeding, you need to be really mindful of medications that could be passed along in the breast milk. So just kind of keeping that in mind if you're considering a pharmacologic option, that it's one that's safe for the baby. And then also, you know, as I mentioned earlier, most of our medications in psychiatry aren't friendly when they come to side effects. So being mindful if someone's already struggling, recovering from a pregnancy and dealing with a lot of things medically, introducing a lot of side effects into the picture is definitely not ideal.
That's a great question in the chat about blind weighing. What is the recommendation for blind weighing? And the question is, I understand that in an inpatient setting that it's not uncommon. However, I've had a few families continue this practice after discharge from inpatient care. What are your thoughts on the blind weighing?
So I can speak to this one because I have a patient in clinic that I saw last week that for several visits was completely refusing to weigh herself. And she's coming to the outpatient clinic specifically for an eating disorder, but also comorbid depression and anxiety. And when I checked the patient out with the fellow, they just said, well, the patient refused to weigh. And I said, well, that can't be an option. You know, the patient's coming in, they're coming in for treatment. Part of their treatment is treating their eating disorder. So not weighing can't be an option. Now, there can be other options, like if they don't want to know how much they weigh, they don't have to look at the scale. I think that's fine. The medical assistant won't say the number, they can face the other direction. For us as clinicians, that gives us a big picture of where they're at health-wise and whether we're making progress with the eating disorder or not. So I would say if the alternative is refusal to weigh and you can't get a weight, I would say blind weighing is, you know, much better in that kind of situation. And I've had a lot of success with it in clinic. For those patients that traditionally would refuse to weigh, if not having to look at the weight, they're okay with it. And that's not necessarily a bad thing too, right? Because we want to correct the behaviors that lead to the eating disorder. We don't want to solely focus on the weight. And it can make the visit be really a dread on the patient's part, and they don't want to come in, they don't want to see the number. And so allowing them to just have their weight checked but not necessarily look at it, I think is okay. But I'm curious to see if Dr. Garcia feels differently.
I completely agree. So in family-based treatment or even cognitive behavioral therapy, when you are taking weight, typically you're taking blind weights because we don't want the patient to focus so much on the number on the scale. And it also could cause a lot of distress for them as well too, especially because the weight is usually taken at the very beginning of the session as well too. And knowing that number can really derail what is going to happen in the session. And so blind weights are recommended. I would say though that after some time progresses, if they have to continue to take the weight at home, it would just depend kind of where they are in their treatment status at that point, whether parents are choosing to continue with blind weights or allow them to see it. But that would be more of like an individual basis on where the status of their progression. But blind weights is definitely, I would say, the preferred method.
Appreciate that. Any other questions? We have about 2 minutes left.
What is the earliest known case of an eating disorder, or the earliest age, or the youngest known case of an eating disorder, versus it being like failure to thrive?
So I don't have an exact age for that answer. I'm not sure, Dr. Shotwell, if you have an idea for that, but we do see eating disorders in children that are as young as 7. You would see like different types of eating disorders, and they may present differently as well too. So like I mentioned earlier, the avoidant and restrictive intake disorder. So that is you usually see that during like infancy and early childhood. But for things with like anorexia or bulimia, there have been cases of seeing that in as young as 7. I'm not sure, Dr. Shell, if you've heard of it younger than that. But that is when you would mostly have parent report of what's happening and focusing on their eating behaviors. And it goes beyond just like being picky and refusing certain foods.
Yeah, so most of my experience is with teenagers, preteens, and young adults. So I can't speak to many patients younger than that.
Thank you. I currently have a 9-year-old that is consistently losing weight with known psychiatric disorders. So I was just wondering.
Yeah, I would say something to keep on your radar if it's someone who's really young, like Dr. Garcia mentioned, 7, 8, or 9, someone in that range, taking a good developmental history and seeing if there are any signs or symptoms of autism spectrum. What may be looking like an eating disorder clinically, when you talk to the family, it may be a food texture issue or, something like that, limiting the patient's intake rather than a desire to lose or maintain weight. So the motivation may be different, which is what sets it apart from being, an eating disorder or not.
Yeah, there is that as well. And then just food refusal.
Yeah, that's the other piece. When it's someone who's really young, a lot of the symptoms can be behavioral, right? You can't control a lot of things as a small child, but one thing you can control is what goes in your mouth or not. And
exactly.
So one way they can control the situation.
Yes, thank you.
Mm-hmm.
This has been an excellent session. Thank you so much, Dr. Garcia, Dr. Shotwell. The questions that you all have had, thank you very much. It's great to have an interactive session where we get those questions, because I suspect if one has that question, we probably have multiple folks who do. So again, thank you very much. We have Meredith on here showing the CME QR code for physicians. We've also put the nursing one into the chat as well, and here it is on this slide. If you have any additional feedback for us, if you want us to send any questions off to our presenters, you can certainly do so. I'm going to put the CPAN email address in here. You can send them to us here at UT Tyler, even though you may be a UTMB person, and I can get them off to Krista, and we can go ahead and get questions answered. If you have additional session topics that you would like, we would love to be able to have that information from you as well. We are building our 2024 CME topics right now. So thank you very much. Dr. Garcia and Dr. Shotwell, thank you very much for your time today. You're excellent presenters. It's been a very important topic to address. And we thank you all and hope you have a great rest of your week. Now you take care.